taking a class on local anesthetics. So some of you have experienced this type of injection. I mean, maybe you would have. I had experience. So this is giving a local anesthetic for a some dental procedures. So what are local anesthetics? They are drugs which upon topical application or local injection cause reversible loss of sensory perception, especially of pain in a restricted area of the body. So when we are giving injection, there will be reversible loss of sensory perception, especially the pain. So that is the local anesthetic, and this is by blocking the generation and conduction of nerve impulse, but it won't cause any structural damage to the nerves or any tissues. So that is what is meant by local anesthetics. See, both sensory as well as motor impulses will be interrupted when we are giving an injection of local anesthetics. And there are some drugs like propranolol, chlorpromazine, H1 antihistamines, quinine, etc. also have some local anesthetic action, but we are not using them for us local anesthetics. Then there are some other methods by which we can make a local anesthesia, that is application of ice. So if we have some pain, if we apply some ice, we will get numbness. So that is the one example. Then carbon dioxide, snow, ethyl chloride, spray, etc. Then this is the classification. Local anesthetic, it can be either injectable, both injectable as well as surface anesthetics are there. So under injectable itself, low potency, intermediate potency, high potency, it is there. Low potency, example, chloroprocaine, sorry. Intermediate potency and duration, it is lidocaine or lignocaine, you would have heard, prilocaine. High potency, long duration, it is tetracaine, bupivacaine, ropivacaine, dibucaine, etc. Then surface anesthetics, soluble and insoluble. It is soluble, it is cocaine, lidocaine, tetracaine, propracaine. Then insoluble, benzocaine, butyl amino benzoate, oxytocin. So out of this, the most important one, it is low potency procaine, intermediate potency lidocaine, and here bupivacaine, it is important, and also dibucaine. And you can see lidocaine, it is also a surface anesthetic as well as an injectable anesthetic. So that is lidocaine, lignocaine, xylocaine, different names are there. Lidocaine, lignocaine, xylocaine, everything, it is same. Okay, so that is the classification. Now, we will see certain structure. So they are local anesthetics, they are actually weak bases with amphiphilic property. What is this amphiphilic property? That is, in their structure, on one end, there will be an amine group, it is hydrophilic. And on the other end, there will be an aromatic group, which is lipophilic. So here it is lipophilic, and this is hydrophilic. So both this is there, and it is also joined by an alkyl chain. It can be an ester or an amide. So there will be an ester linkage or an amide linkage. So that is the structure of a local anesthetic. So, so this is an ester local anesthetic. So that is the ester linked local anesthetic. There is a procaine, and lidocaine, it is an amide linked. So the examples are ester linked are cocaine, procaine, chloroprocaine, tetracaine, benzocaine, etc. So this is the ester linked. Then the amide linked, it is the lidocaine, bupivacaine, dibucaine, prilocaine, ropivacaine. So out of this, most important, it is the lidocaine. And in clinical side, we will be mainly using the amide linked local anesthetic because they are having longer duration of action, less side effects. We will see everything in the following slides. So this is the commonly used, that is the amide linked. Many advantages are there. So we will see all that. So I think you understood. There is an amine group which is hydrophilic, aromatic group, it is lipophilic. It is connected by a alkyl chain with maybe either ester or an amide. So some features of amide local anesthetic. So it produces more intense and longer lasting anesthesia, binds to alpha-1 acid glycoprotein in the plasma, not hydrolyzed by plasma esterases, and rarely cause hypersensitivity reactions and no cross-sensitivity with ester local anesthetics. So this is the important one. Whereas the ester linked, this having only short duration, less intense analgesia, higher risk of hypersensitivity, and so nowadays ester linked, they are rarely used for infiltration or nerve block, used topically on the only for topical application. So that is the most important one is the amide local anesthetics. Please mute your phone. Now coming to the mechanism of action, what is the mechanism by which local anesthetic acts? So you would have seen the action potential. First, when a stimulus comes, there will be entry of sodium and it will reach the threshold potential, and then it will go up and there will be an upstroke with the sodium ions. That is in the action potential. So this local anesthetics, this prevents the entry of or the upstroke of sodium. So depolarization, it is actually blocked. So there won't be any conduction. So sometimes it won't even reach up to threshold potential also. So there won't be any entry of any sodium ions. So that is what it is written. It blocks the nerve conduction by decreasing the entry of sodium ions during upstroke of action potential. As the concentration of local anesthetic is increased, local depolarization fails to reach the threshold potential and conduction block. So there won't be any conduction. That is the mechanism of action of this local anesthetic. Again, we will see some more points. So increasing dose. So this is where this is not untreated nerve. Whereas if the dose is increased, so this is one dose. Again, this is increased dose. So I mean, this is the first dose, and this B, it is the second dose, C is the third dose, and D is the fourth dose. So as the dose is increasing, it won't reach even up to the threshold potential. So that is the effect that if you are increasing the dose, so the complete block actually occurs. Now, some more points about the mechanism of action. Now you know all the channels or everything structures. So this is the sodium channel. So there will be three states. There is a resting state, activated state, as well as inactivated state. So and this will be having two gates. There is a M gate. That this is the opening gate, and this is the closing gate. That is kept in the intracellular area. Niswa, please mute your phone. Yes. When you are joining, after muting your phone, please join. Otherwise, it will disturb our class. Niswa, you can keep your video also off. Video off. Video off, please. Niswa. You don't know how to do it? No. Okay. So this is the local anesthetic receptor that is kept in the intracellular part of the sodium channel. So this local anesthetic, it will be acting only on the activated and inactivated state. I will explain that. See, this local anesthetic, it will be binding to, so once the sodium enters that in the activated state, this local anesthetic, it will bind to the receptor and it will be blocking it. So you can see this inactivation gate. So it is closed. So it will be inactivated and there won't be any entry of sodium. So that is why it will prevent the upstroke of sodium or the entry of sodium. So that is why it acts. Then some more points. This local anesthetics, it may be in the physiological pH, it is ionized. For example, this is the unionized form and this is the ionized form. So for the entry of this ionized form is always, unionized form is always lipophilic. So this lipophilic, this B represents the unionized form. It enters the axonal membrane, but at the physiological pH it will be ionized, and the ionized form, this BH, it will be binding to the receptor. So B won't bind to the receptor. Only the BH, that is the ionized form, only will bind the receptor. So if it is made either only lipophilic, there won't be any action, or only hydrophilic, there won't be entry of the local anesthetic also. So this is important. Both, it should be in equilibrium. The B and BH, it should be in equilibrium. Then only the action of local anesthetic will happen. Then this when okay, what we will see what is written here. The local anesthetic interact with the receptor situated within the voltage sensitive sodium channel and raise the threshold of channel opening. So it will raise the threshold. That is, it won't even reach up to the threshold level also. Then impulse conduction is interrupted when the sodium channels over a critical length of fiber 2-3 yes. When the conduction, that means if it is blocking the entry of sodium up to 2-3 knots of Ranvier, it will be blocked. So you know what is knots of Ranvier? In this knots of Ranvier, lot of sodium, the ions are present. That is why the effect is more seen in the knots of Ranvier. And then one more point, membrane stabilizing effect. What do you mean by membrane stabilizing effect? So I have already shown, 1 minute, I'll just take this as. It will be affecting only the depolarization part. It is not affecting the hyperpolarization or the resting state. So here only sodium channels are only blocked here. So only the depolarization part is affected. It is not affecting the hyperpolarization or the resting state. So this is what is meant by membrane stabilizing effect. That is action affecting depolarization, failure of impulse propagation without affecting the resting potential. So this is called membrane stabilizing effect. So local anesthetic, they have membrane stabilizing effect. And even we have, when we studied beta blockers like propranolol, we have seen there is a membrane stabilizing effect. So this is what is meant by this membrane stabilizing effect. Okay, we will see the next one. Okay, this I have already told. At physiological pH, the local anesthetic molecule is partly ionized. Equilibrium between... Please keep your phone muted. Equilibrium between the unionized base form and the ionized cationic form depends on the pK of the local anesthetic. That is membrane constant. That is a dissociation constant. Then B, it is the unionized form, which is lipophilic, penetrate the nerve membrane. So like this. And BH is the ionized form, active at the receptor. So BH, it is the active at the receptor. So this is the, so at physiological pH, it is ionized. But if you are making, okay, we'll come to that points. Then now some other features, the potency of local anesthetic. This again, the same thing I have written. This is lipid solubility. I think this is a repetition, no need to repeat it again. Okay. Now, this also I have mentioned, it is blockade, it is not due to hyperpolarization, it is only by the depolarization and it won't affect the resting state, and it is called this membrane stabilizing effect. Asna Jabin, have you muted your phone or is it unmuted? Asna Jabin. Asna Jabin. You have kept your phone unmuted and you are left already? Yes. Okay, good. Then the onset time, some of features of the local anesthetic, the onset time of blockade is related primarily to the pK. If the pK is lower, then it will be faster acting. Example, lidocaine. Then pK, higher pK, it will be slower acting. Example, procaine. So lidocaine, it is faster acting because of the lower pK. Now, yes. Now what is happening if we are injecting local anesthetic around a mixed nerve, it will be, it affect all the nerve trunks, neuromuscular junction, ganglionic synapse and receptors, etc. But it is non-selectively because wherever there is sodium permeability, it will be affecting the, this local anesthetic will affect the entry of sodium. And in addition, there will be, it will reduce the release of acetylcholine also. So two actions, it will be reducing the release of acetylcholine as well as entry of sodium is also actually blocked when we are injecting a local anesthetic around a mixed nerve. And so when we are giving an injection, it will cause the anesthesia of this the skin as well as paralysis of the voluntary muscles supplied by this nerves. Okay. Now, when we are giving local anesthetic, usually sensory as well as motor fibers will be equally sensitive, but we have seen there is unequal ability to block most of the drugs. Example, epidural bupivacaine, epidural analgesia. It is used in case of obstetrics during delivery to reduce the pain during delivery. So this bupivacaine, it actually produces sensory block at lower concentration. So at lower concentration, when we are giving, it will block the sensory, it causes the sensory block. So there won't be any pain. But motor block is not happening at the lower concentration, so that the mother is able to, without pain, they able to push the fetus down during uterine contraction. So that is about epidural. So epidural anesthesia you would have heard. So in the afternoon, you will be hearing everything about all the techniques of local anesthetic administration. So that is epidural bupivacaine. Another example is epidural analgesia for knee replacement. That is here also, because of the absence of motor block, immediately after the knee replacement, there will be early ambulation and performance of exercise. If the motor part is also blocked, then he won't be able to walk, or he won't do any exercise. So such unequal ability to block, it is also seen with local anesthetic. Mainly the sensory fibers are at lower concentration, sensory block is happening. So that is an advantage for the with the unequal ability to block. Now, sensitivity. What are the factors which determines the sensitivity to local anesthetic? The diameter of the fibers. The smaller fibers will be more sensitive than larger fibers. And usually, an anesthetic, local anesthetic, the conduction will be blocked up to 2-3 knots. 1, 2, 3. Here also, 1, 2, 3 knots of this Ranvier, it will be covered. That much conduction will be affected. And so one point, it is the smaller fibers are sensitive. Then slender axons, because in slender axons, the knots of Ranvier will be closely placed, and the space between the knots, it will be less. So slender axons are also affected more faster by the local anesthetic. Now coming to the autonomy, yes, autonomy fibers are also, actually the autonomy fibers are affected first. So they are more susceptible than the somatic fibers. And when we see the different sensation, I mean sensation, the taste sensation that is in the tongue, this is the tongue mark. So in the tip, it is actually salty sensation and taste. Then comes a sweet, then on the sides it will be sour taste, and finally on the back it is bitter taste. So if you see, most of our ladies, when you people are not now making anything or doing any cooking, but when we become in your future life, you will be tasting whether there is enough salt in your preparation. So just keep a little bit in your tip of the tongue. You will understand whether it is the salt is enough or not. So that is just a example only. So it is coming in the tip of the tongue. There is salty taste. It is coming in the tip of the tongue. What I was about to tell is, when we apply, if you are applying a local anesthetic to your tongue, first the bitter taste, it will be lost, then followed by, so from behind it is going. So bitter, then sweet, then sour, and finally only salty taste. In addition, the blockade, first it will be happening for pain, and later temperature, then touch and deep pressure sense. Because the pain, it is carried by, we have already seen smaller fibers are affected first. So because the pain is carried by the fibers which are of smaller diameter, so it is affected first. So first the pain will go. So that is, the pain is the first modality to be affected. Okay. See, in this nerve, there will be a nerve sheath. So when you are injecting local anesthetics, this nerve sheath actually restrict the entry of or the diffusion of local anesthetic to the nerve trunk. So the outer layers are blocked earlier. So the areas which are supplied by the nerves from the outer layers, it will be affected first. So that is why in the proximal areas it will be affected first rather than the distal area, because distal areas are supplied by the nerves which is coming inside. So that is the another point about the local anesthetic, which we are just dealing with the talking about the different features of local anesthetic. Now another thing, there will be differential arrangement of various type of this sensory and motor fibers in a mixer. You know that there will be differential arrangement. Because of that, there will be differential blockade also in different areas. So that is also another feature, differential blockade, because of the differential arrangement of the sensory and motor nerve fibers. Now, there is one question. Local anesthetic fails to afford adequate pain control in inflamed tissues. What are the reasons? Why in inflamed area, if you apply local anesthetic, it fails to afford adequate pain control? What are the reasons? Because the inflammation, whenever there is inflammation, there will be it will become acidic pH. It lowers the pH of the tissue. You know that in acidic medium, this will be more ionized. So you know that in the beginning I have told you, for the entry into the axonal membrane, it should be in the unionized form. So because it is ionized, it will hinder the diffusion into the axial lemma. Number one. Number two, in the blood flow in the inflamed area, it will be increased. So local anesthetic will be removed rapidly. Third one, most of the cases we will add adrenaline. It is a vasoconstrictor along with local anesthetic. But because inflammatory products, it will oppose the local anesthetic action. So if at all we are adding adrenaline, its effect won't be seen in the inflamed area. So understood? So there will be acidic medium, so it will be ionized. Because of the blood flow, it is rapidly removed, and effectiveness of adrenaline, it is actually not seen or reduced in the inflamed sites. So these are the reasons why local anesthetic fails to afford adequate pain control in the inflamed tissues. Now, this is another question for your exams. Why we are adding adrenaline which is a vasoconstrictor along with local anesthetic? What are the reasons? So there are many reasons. I have written a few. These are the important reasons. One, because it is vasoconstrictor, it prolongs the duration of action of local anesthetic. It is understood. Then second one, it decreases the rate of removal from the local site into the circulation because of the vasoconstriction again. Then contact time of the local anesthetic with the nerve fiber is prolonged because it is at the site, from the site, it is only gradually removed. So the contact time, it is prolonged. Then it enhances the intensity of nerve block, reduces the systemic toxicity of local anesthetics. Rate of absorption is reduced and the metabolism, rate of absorption as well as metabolism, it is reduced. So keep the plasma concentration lower. Then provide a more bloodless field for surgery. Again, because of the vasoconstriction, it causes a bloodless field for the surgery. Then, but there are certain other negative points also. It increases the chance of subsequent local tissue edema and necrosis, because if there is vasoconstriction, chances of necrosis it is there. And it may also delay the wound healing by reducing the oxygen supply and enhancing the oxygen consumption in the affected area. So these are the reasons, but mainly in all the actions because of the vasoconstrictor effect of adrenaline. So this is the reason. What is the rationale of adding adrenaline or a vasoconstrictor along with local anesthetics? These are the points. Now we will see some of the actions of this local anesthetic. We have seen the different features of local anesthetic. Now we will see the action of local anesthetic in different systems. So first is CNS. CNS usually there will be stimulation followed by depression. This example, cocaine. Cocaine is a powerful CNS stimulant. You have heard of cocaine. So if you take cocaine, there will be euphoria, excitement, confusion. Then afterwards, there will be restlessness, tremor, twitching of muscles, convulsion, unconsciousness, respiratory depression, death. So these are in a dose-dependent manner. But one important thing you have to note here is actually local anesthetic, they are neuronal inhibitors. But why there is a stimulation in the beginning? This is because there is an inhibition of the inhibitory neurons. There are certain inhibitory neurons also. So those inhibitory neurons are inhibited. So there will be stimulation. That is why there is a stimulation followed by depression. So actually the basic action, it is neuronal inhibition. But because of the inhibition of the inhibitory neurons, there will be stimulation. So then later on, Fissa Karim, Fissa.
Yes, ma'am.
You are joining the class only now?
No, ma'am, I joined early.
Then you are keeping your phone unmuted?
No, ma'am, by mistake.
Okay, no problem. Okay, so this is the CNS effect. Now on the CVS, they are cardiac depressants. But so you'd have heard about the already you had classes on antiarrhythmic. You had seen all these drugs, procainamide. It is a class 1 antiarrhythmic agent. Then bupivacaine, one drug, it is cardiotoxic. Then lignocaine, again you have studied because it doesn't have much cardiotoxicity. So it is one of the most important antiarrhythmic drugs. So in the heart, they are cardiac depressants. Because of that, they are used as antiarrhythmic agent. Then blood vessels. Its effect, the basic effect, it is tend to produce fall in BP because of the sympathetic blockade. And this bupivacaine, it is having more sympathetic blockade and it is vasodilatory and there is a more BP fall. But one exception is that cocaine, this is an exception. It is having sympathomimetic property. So there will be increased sympathetic tone, local vasoconstriction, then marked rise in BP and tachycardia. So already it will be causing. So along with, usually we are not using for local anesthesia, but cocaine, so we can just say theoretically, so since cocaine causes local vasoconstriction, no need of adding any adrenaline along with cocaine. But we won't add that, just a theoretical point I am just explaining. Because it is having sympathomimetic property. So that is so we have seen all the CNS, CVS as well as, blood vessels. It causes a fall in BP. Now, pharmacokinetics. This soluble surface anesthetics like, lidocaine, it is injectable as well as surface anesthetic, also tetracaine. And they are actually rapidly absorbed from the mucous membrane and abraded. Abraded means there will be cut areas. But if you are just applying a local anesthetic on the intact skin, the absorption will be less, very minimal. And the rate of absorption depends upon the blood flow also to the area of application. And since local anesthetic, because lipophilic, it will be widely distributed also. So that is about the pharmacokinetics, the absorption only from the mucous membrane and abraded area, and it depends upon the blood flow as well as the lipophilicity. And they are lipophilic, so it will be widely distributed also. Then about the metabolism. Ester-linked local anesthetic, that is procaine, they are actually two types of mechanism, the metabolism, hydrolyzed with the plasma pseudocholinesterase and remaining by esterases in the liver. Whereas amide-linked local anesthetics like lidocaine, It is only degraded in the liver microsomal enzymes by dealkylation and hydrolysis. This is one important point. Ester linked, it is from the plasma mainly. Amide linked, it is in the liver. This microsomes, it will be by dealkylation and hydrolysis. So that is about the pharmacokinetics. Now coming to the adverse effects. So now it is self-explanatory. CNS effect. CNS, because of the depression, there will be lightheadedness, dizziness, auditory and visual disturbances. So that is a CNS effect. Cardiovascular toxicity, we have already seen there will be BP fall and bradycardia. It can occur only cocaine. It is sympathomimetic. It may increase the BP. Then at the site of injection, it may be painful. Wound healing, we have seen it may be delayed. Then hypersensitive reactions like rashes. It is more common with, in the beginning we have seen these allergic reactions or the hypersensitive reactions are more common with ester-linked local anesthetics. And there is a preservative that is added along with this ester-linked local anesthetic. It is called methyl paraben. So some cases it may be due to the allergic reactions, may be due to the methyl paraben, which is added as a preservative along with the ester-linked local anesthetic. So that is about the adverse effects. CNS effect, lightheadedness, cardiovascular toxicity, mainly hypertension. Then injection at the site, it may be painful, hypersensitive reactions. Now, certain precautions. When we are giving this local anesthetic, we have to be careful. There are some precautions because when we are injecting local anesthetic, please be careful. It should not go into vessels. So avoid intravascular injection. You know all the side effects, so be careful. Then it has to be injected slowly and take care not to exceed the maximum safe dose. Okay, so that is number 2. Then this we have already written in our records, but even again I will be explaining. Propranolol, like it's a beta blocker. There are 2-3 reasons are there. So it may reduce the metabolism of the lidocaine and other amide local anesthetic by reducing the hepatic blood flow. This propranolol beta blockers, it reduces the hepatic blood flow. We have already seen that the metabolism of amide local anesthetic, it is happening in the liver. So if they reduce the hepatic blood flow, this propranolol, it will reduce the metabolism of lidocaine. That is along with propranolol. Then adrenaline, we have already seen they are a vasoconstrictor. It is added to prolong the action of this local anesthetic. But because it is a vasoconstrictor and it is adrenaline, it is sympathomimetic, we have to be. So if there are people with ischemic heart disease, cardiac arrhythmia, thyrotoxicosis, uncontrolled hypertension, we should not add vasoconstrictor along with local anesthetic. And also those receiving beta blockers. This we have already seen why we should not add adrenaline along with local anesthetic in those receiving beta blockers like propranolol, because we have seen it will be blocking beta 1 as well as beta 2, and there will be unopposed alpha action and there will be rise in BP. Unopposed alpha action, that is vasoconstriction. Or those receiving tricyclic antidepressants. Tricyclic antidepressants, again, it will uptake the blockade and potentiation of adrenaline. So uptake inhibitor. So there will be more of this adrenaline. So such cases, we should not add a vasoconstrictor along with the local anesthetic. You understood? So vasoconstrictor should not be, adrenaline, usually it is added along with local anesthetic to prolong the action as well as reduce the systemic toxicity, everything, etc. But it should be avoided in patients with ischemic heart disease because of the adrenaline and cardiac arrhythmia, thyrotoxicosis, and uncontrolled hypertension. And those receiving beta blockers, because beta 1 and beta 2 is blocked, so there will be unopposed alpha action. And also tricyclic antidepressants because they are uptake blockades. Then, so that is the precaution. So injection, be careful. It should not be intravascular. Give slowly. Then other beta blockers, we have to be careful. Then felipressin, it is a synthetic vasopressin. So such cases, see, we have seen that this adrenaline, we cannot add to local anesthetic in ischemic heart disease and such cases. So such cases, we can go for a drug called felipressin. It won't affect it won't make any problem in this condition. So we can add felipressin along with this. It is a synthetic vasopressin. It will cause vasoconstriction and it will prolong the action of local anesthetic. So this is preferable in the cardiovascular disease. Oh,